Welcome everybody. Thank you so much for joining us this evening for this educational webinar on understanding melanoma drug therapy and the new era of neoadjuvant. My name is Shannon Anderson and I'm the CEO of Melanoma Patients Australia, and I'll be facilitating this webinar this evening in partnership with Melanoma Institute Australia. Melanoma Patients Australia is a not-for-profit, community-based organisation that provides support services, including information, telehealth nursing and peer-led support groups nationally to melanoma patients, family and carers. Our purpose is to support, connect and advocate for Australians affected by melanoma and to work towards its prevention. Melanoma Institute Australia is dedicated to preventing and curing melanoma through innovative world-class research, treatment and education programs. And Melanoma Institute Australia's mission is to reach 0 deaths from melanoma this decade. I will introduce tonight's speakers shortly. But just importantly, I'd like to do an acknowledgement of country. I'd like to pay our respects to the traditional custodians of the lands on which we're all located today. I'm located on the lands of the Wurundjeri people of the Kulin Nation in Melbourne, and we'd like to pay our respects to elders both past and present and acknowledge the deep and continuing connection of Aboriginal and Torres Strait Islander peoples to the land, waters and sky. And I'd like to acknowledge any Aboriginal and Torres Strait Islander people on this webinar this evening. So just a brief bit of housekeeping. This webinar is being recorded. And the recordings will be available on both the Melanoma Institute Australia website and the Melanoma Patients Australia website in the coming days. In terms of the Q&A sort of function, you are able to type any question using that Q&A button, but importantly, the questions must be of a general nature, and we are unable to give any personal medical advice in this forum. We do value your feedback, so please complete the brief online survey after the webinar, and the link should appear at the end of the webinar. We will endeavour to address questions throughout the webinar, and there will be a formal Q&A section at the end. So just a reminder also, next week there is a final webinar in our series, which will be a deep dive into sunscreen, and that will be next Tuesday evening at the same time. And for anyone who missed the first webinar in our series last week on genetic testing for melanoma, the recording of that session or that webinar is already available on both the MPA and the MIA websites. So it's certainly not too late to register also for the session for next week. So just in terms of introductions now, I have the great pleasure to introduce Professor Georgina Long. Georgina is the medical director of Melanoma Institute Australia and the chair of Melanoma Medical Oncology and Translational Research at the University of Sydney and the Royal North Shore Hospital. Georgina is a world-leading melanoma expert. She has led pivotal research into immuno-oncology and targeted therapies, with over 570 peer-reviewed publications. Named 2024 Australian of the Year, Professor Long is a Clarivat highly cited researcher and was ranked equal #1 melanoma expert globally in 2025. She is past president of the Society for Melanoma Research and holds leadership roles with ASCO, ESMO and AGCC. I'd also like to introduce Associate Professor Alexander van Akkooi. Alexander is an associate professor in the melanoma surgical oncology at MIA and Royal Prince Alfred Hospital, the University of Sydney. He has extensive research and clinical experience and has served on several international committees, including recently as chair of the EORTC Melanoma Group. I'll hand over to Professor Georgina Long, who will speak first, and then following that, Associate Professor Alexander van Akkooi will present after that. So I'll hand over to you, Professor Long.
Okay, thank you. Can you hear me okay? Can someone give me a thumbs up? Yes, great. And now I'm just going to share, thank you. I'm just going to share my slides. Can you see my first slide says third space curing cancer? A thumbs up will do. Yes, wonderful. Thank you. So I'm really pleased to be able to present this data. Now, Alex Van Akkooi and I work very closely together as a medical oncologist and a surgical oncologist, along with our colleagues at Melanoma Institute Australia. And I'll be talking about drug therapy, and Alex will be talking about the surgical aspects when we use drug therapy with our patients. But before we talk about that, I just want to talk about what we're trying to achieve at Melanoma Institute Australia and across all of the academic institutions in Australia around the world. This is how I think about curing cancer as someone who uses drug therapies. If we take a bunch of people with cancer, and now I'm going to talk about melanoma specifically, we know that if you have advanced melanoma where it's spread around the body, about 40 to 45% of Australians are going to be responsive to what we call anti-PD-1 immunotherapy. And the majority of those people are cured or have long-term durable control. Another 10 to 15% have benefit when we use two immune treatments together. And I've listed the names underneath there of the drugs that we use in clinic regularly. These are drugs that are on the PBS and are available for all patients with advanced melanoma, so melanoma that's spread around the body. But my area of particular interest is this group here, and I call that the third space. And every cancer will have some responsiveness to anti-PD-1. It might only be a few patients for some cancers, and some responsiveness to dual. And again, it might only be 5 to 10%. But my focus is in this third space of melanoma, which will help other cancers to try and understand why people are not responding to classically used immunotherapies and what immunotherapies we can use to try and cure them. This is one of my patients, Adam. He was 37 when he developed advanced stage melanoma. Now, not everybody's in his shoes. Unfortunately, none of the standard treatments were working on him. And at his time, they were still in clinical trials, some of these treatments that we were using that are now standard, but they did not work. And that is where we are focusing our attention in our trials and research. I'm going to be talking about the neoadjuvant. In fact, this whole session is on neoadjuvant treatment in melanoma, but from the medical oncology and drug development perspective. So I've got three things I'm going to cover today. When do we use drug therapy in melanoma? And what exactly is neoadjuvant therapy? How do we work out if drug therapies are working? And lastly, what are we doing next to increase survival? So what are we doing in what I call that third space? So when do we use drug therapy in melanoma? And many of you would be very familiar with this, but it's important to go over this. So there are 4 stages to melanoma, stage 1 and 2, and this is cutaneous melanoma, the most common type of melanoma. I'm not concentrating on mucosal melanoma or uveal melanoma, the less common subtypes of melanoma, but those two cancers are very much in the third space, so is an area of intense research for us. But today I'm mainly focusing on cutaneous melanoma. So stage 1 and 2 is the original melanoma on the skin, often pigmented, not always, but it has not traveled anywhere. And they are cured with simple surgical excision, although a proportion of those patients do develop what we call advanced melanoma. Then we have stage 3 melanoma, where you have your primary lesion. Sometimes we don't find the primary, the original melanoma, but it spreads to nearby lymph nodes. So in this cartoon, it's at the neck. And then we have advanced or stage 4 melanoma, where melanoma spreads around the body to distant sites. So where do we use drug therapy? We use it in 3 different circumstances. Firstly, on the left, what we call adjuvant, and that's after the melanoma has been surgically removed, and we have it approved for stage 3. So this patient has a melanoma that has spread to the armpit lymph nodes. It's only stage 3. It hasn't spread far and wide. And it is standard treatment, or it used to be standard treatment, that we would resect those lymph nodes And then we would give adjuvant treatment afterwards. That's adjuvant, mop-up treatment. What are we trying to do? The tumor, the big tumor's gone, but we know there might be what we call micrometastases. These are little microscopic cancer cells we can't see on scans, and the drugs mop them up. And so, are we still going? I've lost my slides. Let me just find them. Sorry, I don't know what's happened, so I'm going to have to put my slides back up and share. Okay. No, you don't want that. Stop share. Can you see that now? Can someone give me a thumbs up? Yep, thank you. I'm not sure what happened then, but let's hope it doesn't happen again. So micrometastases, I was saying, these are things we can't see, the cancer cells we can't see on a scan. And the idea is the drugs mop them up. And there are 3 drugs we can use for stage 3 after surgery, and I've listed them there. The dabrafenib and trametinib are BRAF and MEK inhibitors, and the Nivo and Pembro are very similar. They're called anti-PD-1 immunotherapies or checkpoint inhibitors. Neoadjuvant, on the other hand, is where we give the drug first. Very similar circumstance, still a stage 3 patient, but this time we give the drug first and then we resect the tumor afterwards. And I'm going to talk about that in a bit more detail. And the current drugs we have available on the PBS to all Australian are pembrolizumab. We don't yet have nivolumab and ipilimumab in combination, but we hope to soon. And I'll get to that in a minute. And then lastly, we have advanced melanoma, and that can be stage 3 or 4, and it's basically not resectable. We can't get it out by surgery. It'll just keep popping up. And we have a whole list of drug therapies. The first 3 is Nivo or Pembro, again, single agent, or these doublets, Nivo plus ipilimumab or nivolumab plus relatlimab. And they're 2 different types of immune treatments. Then we have these BRAF and MEK inhibitors. There's 3 different types. They're exactly the same, just different side effects. So how do these drugs differ? I talked a little bit about the BRAF and MEK inhibitors. They are called targeted therapies. About 40% of patients with melanoma will have a BRAF mutation in their melanoma. And then I spoke about checkpoint inhibitor immunotherapy, and I'm just showing you a picture of a patient who was treated with anti-PD-1. This patient was treated with pembrolizumab, but it could have been nivolumab. So the patient on the left, terrible melanoma, completely disappeared with the targeted therapy. However, it did come back for him at about the 14-month mark. This patient had anti-PD-1. You can see it was in the neck and in the liver, and it completely disappeared and it's never returned. And he's now 10 years down the track. So this just shows you how effective sometimes the drugs can be, particularly the checkpoint inhibitors long term. They're associated with a good survival. How do these drugs differ? The targeted therapies kill the cancer cell directly. So they kill the melanoma cell directly, not the checkpoint inhibitors. The drug does not kill the cancer. The drug activates immune cells, particularly what we call T cells that we all have, to kill the cancer cell. And I already gave you the names of those drugs, but just to reiterate, these are the BRAF and MEK inhibitor combinations, and these are different PD-1 drugs and different combinations with other immune therapies. Now, given time, I'm not going to be able to show you how the drugs actually work and how they interrupt a handshake between the cancer and the T cells to allow your T cell to kill the cancer. I'm going to go straight to talk about neoadjuvant therapy. So neoadjuvant therapy is where we give the drug first, as I explained before. We usually give it for 6 to 8 weeks, 2 or 3 doses, depending on the drug and how the person is going with the drug. Then we resect. It gives us an opportunity to collect biospecimens along the way. It also then, when we get the tumor resected, which is what Akkooi does, We then send it to our pathologists and they look down the microscope. Pathologists don't see the patients, they see the patient's specimen and they tell us how well the patient has responded. So we have 4 categories: complete response, no tumor cells left. So TC is tumor cells. Near complete is less than 10% tumor cells. Partial is between 10 and 50% tumor cells, and no pathological response is more than 50% of tumor cells. So remember those 4 categories. I'm really just going to focus on the 2 extremes to demonstrate why this way of assessing in the neoadjuvant platform with the pathological response. We do use scans as well, so we do CTs or PET scans, but having the pathological response, we get to see the actual biology and how well the tumor has responded to the immune stimulation. Just to note, when we lump these 2 together, they behave very similarly, and they're called major pathological responses. Now, I'm not going to show you many curves. I've just got this 1 slide of curves, but these were the 2 very important papers. These were published in the New England Journal of Medicine. And I want to point out, because it may not be commonly known, when you see these big studies, the leading people or the senior author, that's me there, and the first author are the lead authors of the work. So here it was a medical oncologist, her name's Sapna Patel and Tony Rebus, and for the Nadina, Christian Blank in the Netherlands, and myself in Australia, and all our colleagues around Europe and Australia did these trials. So Christian and I designed this trial called Nadina around 2018, 2019, and then we conducted it here, MIA across Australia, and the Netherlands conducted it across Europe, and we put all of our data together. So the first trial, which was in America, was a phase 2 trial of just pembrolizumab, checkpoint inhibitor. I'm not going to go through it in detail except to say some patients, half the patients got adjuvant pembro, so just after surgery, and the other group got it before surgery, neoadjuvant, and after. And simply by using the same amount of pembro, 18 doses, but simply putting 3 before the surgery, we saw this massive improvement in what we call the event-free survival. So 100% of people up here don't have an event. And then as you go in time, this is time, people have an event. And we see that the neoadjuvant, the blue curve, have less events. What's an event? An event is either the cancer coming back, a recurrence, or someone dying from the cancer particularly, but from other causes, or progressing in your lymph node before surgery. Those are the main things that drive this event. And you can see that people who got the neoadjuvant treatment, exactly the same, did a lot better. In the Nadina trial, we see an even better result with neoadjuvant ipi-nivo. So you can see that this is over 10% higher than this curve. We should not compare across trials because they're done at different eras and different patients, but you can get the gist that the combo is slightly better than the single for some patients, not all of them. And then adjuvant pembro and the adjuvant nivo, that's the control arm where you just get it after surgery, were exactly the same. So very pleasing results to show that giving drug immune stimulant before surgery works better. Why? The reason is the enemy is still in the body and it trains your immune system better when given while the tumor's still on board. So giving it neoadjuvantly, you get a better long-term result, better immune memory against the tumor. We hope that we get PBS listing for this soon, and I hope there will be good news very, very soon that all Australians can get the ipi-nivo neoadjuvantly for stage 3 melanoma that can be removed by surgery. Now, what does this really mean for you, and how does the pathological response give us so much information? So I've just put here the neoadjuvant regimen here, where you have the drug, then the surgery, and then the pathological responses. Green person is alive, red person deceased. So if you get a near complete or complete response pathologically, At 3 years, only 2 people die from their melanoma. And in fact, we believe that all of these other people are cured. So it's great feedback. If you've had 10 to 50% of your tumor remaining, so it's a partial response, then we see that only about 12% of people will die from the melanoma. And if you don't have a pathological response, then we see a few more people will die from the melanoma. And these reds are where we're focusing our attention because we want to get to 0 deaths from melanoma. But we have to say how wonderful it is that we're curing all these other people. That was not happening 15 years ago. Lastly, I just want to really emphasize why this is so good for patients. First of all, there are 3 things that happen when you give drug first. Number 1, you get a refined prognosis. I just showed you the survival data for when you have a complete or near complete versus non-pathological response. We then can tailor your treatment after surgery, and we can tailor surveillance. It reduces the toxicity risk, improves quality of life, we've measured that, and it also reduces the health economic impact on individuals, but also on our community. So it is a really fabulous treatment. I'm going to show you again the refined prognosis. This time, I'm not going to show you the survival, the live versus people who die. I'm going to show you the recurrence rate. So if we look at people who have a complete pathological response, only 4% will recur at 3 years, and often they're curable, leaving only 2 that may die in time, unfortunately, and that's where we're focusing our energy. But if you have a pathological non-response, 71% will recur at 3 years. So now I'm going to show you a bit more data. So this is why patients love neoadjuvant, because they get real-time prognosis feedback. Oh, fantastic. I had a complete response. I'm going to be fine more than likely. In fact, I've probably got more harm crossing the road every day. However, the pathological non-response is information, and that's power for someone. Okay, I've had not a great response. What can I do now? How can I improve my outcome? And here is the tailored adjuvant treatment. So that's the treatment afterwards. So if you've had a pathological complete response, if we give you more drug afterwards, we don't, and the types that are available, so the single agent PD-1 or the BRAF/MEK, we actually don't change your recurrence rate. It's still the same and it's very good. However, if you have a non-pathological response and we give you drug therapy, we can reduce it by an extra 12 to 15%. So we can do something to reduce the red group. That's just recurrence. This is not survival. So it allows us to tailor the treatment. And this is the area we're focusing now, doing trials here in this group. If you haven't had a pathological response, what trial drug can we give you? Lastly, when you have a major pathological response, so complete or near complete, we're able to stretch out your scans, decrease radiation exposure, decrease traveling to the doctor. If you haven't had a near or complete pathological response, you remain at your 3 monthly scans. I'm not going to go through this, but we now have benchmarked a whole heap of drugs and their pathological response rate so that we can develop drugs quickly using this platform so we can get to a cure faster. And I'm just going to end on what we're doing to increase survival in melanoma. This is a slide, and I won't go through it in detail, on all the different types of mechanisms of treatments we're trying to use. We've got things called bispecific T-cell engagers. So instead of pushing the immune cells into the tumor like we do with the PD-1 therapies, we pull them in with drugs like this. We've got many drugs using mRNA technology, not just vaccines, but other really exciting molecules. We've got antibody drug conjugates where we bring a payload in close to the cancer to kill it. And then we've got cell therapy, where we take cells out of the patient's tumor, grow them, and infuse them back into the patient. We've got intralesional treatments, we've got cytokines, and in fact, our focus is on people like Adam. We are trying to cure more people. At the moment, we're recruiting for 17 trials, different stages of melanoma. We've got 30 trials in follow-up, and we've got 8 trials that will be opening soon. So a large array of trials, and we try our hardest to find something for everybody if things are not working with some of our standard treatments. Our last slide I want to show you is a trial we're about to open, we're excited about. And this time we're using biomarkers. So the previous slide was just the prediction tools we have online, melanomarisk.org.au, but we're going to be adding more for neoadjuvant treatment. But now we're trying to use a test at the get-go. So we're taking all stage 3 patients. We're doing a test at the very beginning. If the test tells us that you're going to respond well, it's on the tumor, you go and have your standard single PD-1 drug. You're going to do great. If you're predicted not to do well on a single PD-1 immunotherapy, you are randomized. We call these patients that third space to escalating doses of checkpoints. But in fact, we are going to be rolling in novel drugs into this trial design. And what we're looking at is the pathological response. There is going to be an opportunity that if you don't have a good response, we may be able to add in experimental treatments here at this point, once we see you have not had the best response, but that's not starting yet. So I just want to finish off. When do we use drug therapy in melanoma? Well, we use it adjuvantly in stage 3, so after surgery, neoadjuvantly before surgery, and that's really making a massive difference to our survival rates, and then advanced disease when it's not resectable. How do we work out if drug therapies work? Well, we use scans all the time, but with the neoadjuvant platform, we use the pathological response. It is super, super sensitive to how well people are going to do long term. And lastly, what are we doing? Trials of novel drugs, and they're biomarker driven, so we can get to that third space faster. And that is my huge area of interest. This is a photo of the trial staff. You can see it's a huge group at MIA, and all of the team and the lab at MIA. And I just want to thank the patients and the families who have been part of clinical trials or part of developing some of these paradigms that really are changing the oncology field, not just melanoma. Thank you. I think we're having discussion at the end and questions at the end. I'd now like to hand over to Alex van Akkooi to talk about the surgical aspects.
Thank you, Georgina. And like in clinic, we work well together. You have definitely eased my job in setting the stage for my talk.
I didn't get to introduce you properly, Alex, and say Alex is one of our lead academic surgeons. He's well known across Australia now. He came from the Netherlands a few years ago, but he's also well known across the world as one of the key melanoma surgeons. So thank you, Alex, and take it away.
Thanks, Georgina. So I get to talk to you today about the surgical aspects, and particularly about surgery after Georgina has given some drug therapy. These are my disclosures. So if we look at a classical approach to a melanoma case where it is stage 3, as Georgina has described, where there's spread to the lymph nodes, you can see here on the right-hand side a PET scan of a patient where it is in one of the groin lymph nodes. So that bright red spot in the center, that is actually the bladder. That's a normal activity because that radioactivity, you pee it out at the end of the PET scan. But you can see that spot on the far right, that is actually a lymph node that is bright in red and yellow in the groin of that patient. On the left-hand side, you can see the anatomy, and you can see that those lymph nodes, and they're in 3 colors. You have the black lymph nodes, the green ones, and the yellow ones. So this is one of those yellow ones. And this is quite a typical location for a melanoma to spread if it's a melanoma of one of your lower limbs. If it's originates from the leg, this is often the first port of call where we find that that type of spread. And historically, in these cases, we would then remove all of those yellow lymph nodes. And even decades ago, so before we had any effective drug therapy, which was about 15 years ago when we started to first get effective drug therapy for advanced melanoma, there was a large focus on surgery, and often more extensive surgery, because we didn't really have any good drug therapy options. So if you progressed to an advanced melanoma case, we really didn't have to offer much to you. So we used to remove the yellow and the green lymph nodes. The black lymph nodes were not usually removed in these cases. And that is quite a significant type of operation. Of course, Georgina showed you the illustration of a patient where it's the lymph nodes under the arm. Could also be the lymph nodes in the head and neck area. But having said that, even in the case where we didn't have any effective drugs, we were still able to cure a proportion of patients with surgery alone. So no drug before or after. So here on the right-hand side, you can actually see that illustrated. Patients with a 3A melanoma had the best prognosis, the best chance of cure. 3B less, and even 3C, the worst cases with many lymph nodes involved in the groin or the neck or the armpit. We still managed to cure about 1/3 of those cases with surgery alone. And this is data from 2009. Now, fast forward to 2017. So this is the most recent data that we have. We can see we now have 4 categories rather than 3 categories. And we started to develop these immunotherapies, particularly for advanced melanoma by this time. Some of those patients were able to access it from this analysis. Some of the patients were still from an era before that was possible, or for countries where there was no access yet. You can see that those survival chances have been bumped up by this point in time. One of the important things to consider is that lymph node surgery, where we remove all of the lymph nodes, and something that might be familiar to you also if you have people in your family or friends in your circle that have to deal with breast cancer. Used to be quite a typical thing in breast cancer as well, to remove all the lymph nodes under the arm. That's quite a significant operation if we have to remove all of them. And the chance of having surgical complications is near 50%, although those complications are often what we call short-term, and we can manage them with antibiotics or wound care, all of that. It still is quite impactful on you, the patients. So we don't like doing them as surgeons because we know that there's a high chance that you will have some sort of complication as a result of this surgery. We do it because we think it's good to get rid of your cancer and help cure you. One of the particular side effects that we often worry about is called lymphedema. It means the swelling of your leg or your arm as a result of that surgery. And you can see there's different stages, different degrees of that happening. I have to say stage 4 is very, very rare, but stage 1 and 2 is quite common after this type of surgery, with about a quarter of patients developing it if we have to remove the lymph nodes under the arm. But even rates of more than 50% have been reported for people that undergo the groin lymph node operations. So Georgina already showed you this. These are 2 very important studies that really set the new standard of giving drug first and doing surgery after. The thing is that we still, these are fantastic results, but we still did that classical surgery where we removed all of the lymph nodes. However, we have one study, which is called the Prado study, where we tried to do it a bit differently. So before we went on to do the Prado study, we first did in a previous study where we still removed all of the lymph nodes. We used this very small magnetic seed, which we put into that lymph node that you saw on that first PET scan of that patient. And the reason to do so is that if a patient responds really, really well to the immunotherapy, then we might not be able to really feel or find that lymph node easily anymore. So this is a clip that helps us navigate towards that lymph node to be able to remove that lymph node selectively rather than having to remove the lot of them. Well, in this case, we still removed the lot of them as well. So in the surgery, we removed all of the lymph nodes, but we first removed that one clipped lymph node, and then we asked our pathologists, well, can you compare the response in that clipped lymph node, which is the largest lymph node that people had when they started the drug therapy, compare that to the rest of the lymph nodes and see what the response is. And as you can see, it's a small study, but in 12 out of 12 cases, we actually found exactly the same response in that index node. So we use this concept to test that in another study. And this is a very complicated chart, I understand, and I'm not going to bore you with it. But basically, what we did is we gave all the people immunotherapy, and rather than removing all of the lymph nodes, we simply removed the clipped lymph node. And then we had that traffic light system where we looked at the response in that lymph node. And if you had a very good response, as you can see, that's the top group in green, where nearly all of the cancer or all of the cancer had been cleared by the immunotherapy. We didn't do any more surgery or any more immunotherapy in those cases. For the other cases that had less of a good response, we still did more surgery and or more drug therapy after. So here you can see that we again had a very high chance of having a good result in those patients. Nearly half of the patients had what we call a complete response, meaning after 2 doses of immunotherapy, there was no more cancer left in that lymph node. 12% of patients still had a little bit of cancer, no more than 10%. Altogether, that is that green category of 61%. So nearly 2/3 of patients had a really good response to that combination of immunotherapy. So that means that 99 patients started on that trial, but only 30 of them needed to undergo that complete clearance of the lymph nodes as their primary surgical management because of a less than optimal response. So we were able to avoid nearly 70 node dissection surgeries and just do a smaller surgery in these cases. Now, what does that mean? Well, this is again quite a busy slide, but what you can see is that the rate of complications is significantly reduced if we do less extensive surgery. And particularly the third one I'd like to draw your attention is the lymphedema rate. That's about 5% chance of that happening if we just remove that single node, 39% if we have to do the lot. That translated into an improved quality of life, which is ultimately possible if we can do less surgery due to the fact that we have effective drug therapy. Then we can also improve quality of life compared to that extensive surgery. So before I head to the next slide and finish off my talk for tonight, the thing is, this is a single trial of 100 patients, nearly 99 patients. It hasn't been tested in other trials worldwide, and the follow-up of these 99 patients was still somewhat limited. We're having an update of that being published soon. So worldwide, people are still doing the full removal of all of the lymph nodes. So we need a way forward to be able to get rid of that and start implementing this Prado concept of that index lymph node for the future. So for that purpose, we've designed, with the help of the consumer group at Melanoma Institute Australia, which involves patients, but also primary caregivers as GPs, we developed this trial where we essentially compare those 2 approaches, surgical approaches, the classical one, where we remove the lot in green on the top, or the bottom one in blue, where we do that index lymph node with that clipped lymph node. So I won't bore you with the details of this trial much more than this. I will say that we are very much looking forward to this trial starting. It's called MSLT3, and we have received an NHMRC grant for this of 3.2 million in Australia. So we will start the trial in August or September of this year. At the same time, the trial will also run in North America, so USA, Canada, Europe, the EU, and Great Britain, and potentially also in Israel, Brazil, Japan, and New Zealand. So we have a lot of collaboration internationally, and it is a great honor that this is being led through MIA. MSLT1 and MSLT2 have also been pivotal studies in melanoma surgery that have been done in the past. They were led out of the US, so now it's Australia's turn, and I'm very grateful for all the help and participation from the Australian colleagues and patients and families for this purpose. So with that, to summarize my bit of the talk, surgery has been and remains a cornerstone in the treatment of melanoma, early stage, stage 1 and 2, and stage 3. But there's an evolution of surgery going on, and drugs have made that possible. Less surgery means less complications and a better quality of life. And we have to have good teamwork and coordination. As you can see between Georgina and I, it's a very natural flow. That is essential to deliver state-of-the-art multidisciplinary care. And we can't do it without our nurses, our fellows, radiology, pathology. Everybody's very much involved because it requires all of us to be on top of our game. With that, I'd like to also just finalize with drawing your attention to this new brochure that we've developed at Melanoma Institute Australia on neoadjuvant immunotherapy for melanoma. It's patient information. It's on our website, freely available and downloadable. Thank you.
Thank you so much, Alexander, and also Georgina. That's an incredible sort of amount of information and really exciting work in terms of the innovations, the clinical trials. There's sort of so much valuable information for people to digest. So I'm now, I'd just like to introduce this evening our Melanoma Patients Australia community member and patient, Amanda Smith. Mandy Smith is a relationship counsellor from Heathcote, Sydney, who specialises in couples work and group programs focused on domestic violence, aggression and addiction. She was diagnosed with stage 3B metastatic melanoma in December 2024 and is currently undergoing immunotherapy following surgery in early 2025. Outside of work, Mandy enjoys hiking, reading and creating essential oil blends, and is a mum of 3 grown kids, Oscar 23, Lauren 21 and Liam 19. Mandy, I'd just like to hand over to you.
Thank you, Shannon. And hello, everybody. I'm just going to share my screen. And if I can have a thumbs up that this is visible or not. No, maybe not yet. Or it is. Okay. Okay. Good. Well, I have 10 minutes, and Shannon, please let me know when I have to start wrapping up. I'll keep my eye on time if I can, but I do tend to chat, so I'll just keep moving. This is a photo of my family. This photo was taken the day after I found out that I had metastatic melanoma, so this was taken on the 4th of December last year, and I was not in a great place emotionally. It was a really, really scary time for me. Just a little bit of background, just to give you some context. I spent my childhood growing up in the northern beaches of Sydney. And for any of you who know that area, it is all surf and sand. I'm 59. So back in the 70s, we had zinc cream. Zinc cream on the nose, zinc cream on the shoulders was basically the extent of our sun care. coconut oil or reef oil was lathered for maximum tanning. Being at the beach and having a tan was equal to being cool. So that was what we did in the summertime, was get a tan. Blonde hair and brown skin. That was me. Yep, I sunbaked a lot and used a tanning bed. Wow, do I regret that? So fast forward to 1999, I had a melanoma that was on my right side of my back. It was a Clark 3 to 4, 1.5 millimeter, which I think is about a stage 1B. And it was completely excised, and I forgot about it. I would always get my skin checked, and I really, by then, I sort of stopped the sunbaking thing anyway. But I was really careful from then on. But still, I never really thought about it very much until October last year. For one day, I had a bit of sensitivity under my arm, and I felt in there, and there was a lump. And I thought, oh, that's a bit weird. And the next day, it wasn't sore anymore, and I forgot about it. But a couple of weeks later, I realized the lump was still there. And I went off and had ultrasounds and what have you. And then found out 3rd of December last year that I had stage 3B metastatic melanoma. I found this out when I was driving to work, and my doctor phoned me to tell me that, my GP. And the next 10 days were absolutely horrific. It was a terrible, terrible time in which I had scans and what have you, and had my first appointment with my surgical oncologist there at the Melanoma Institute. And we found that my melanoma had, from my primary one 26 years prior, had a cell all that time back had found its way to a lymph node and quietly just grew over that time. I then started the neoadjuvant treatment Keytruda, which is the Pembro, and that was 3 infusions once every 3 weeks, which commenced just before Christmas. And I was absolutely terrified. When I first went to have that first infusion, I was sitting in there in the Mater Hospital crying because I was absolutely terrified that all of this was happening, and so scared of the immunotherapy. But for me, my tolerance of it was really good. I've never really had any issues. Exercise, work, everything, and I was, very thankful for that. And so much of what I'm covering here is what Professor Long was talking about how it's administered and so on. But blood's taken a few days prior to each infusion, and lots of contact if needed through that time. So I found that I had loads of support through this time that was, it was just so scary. I had, and what was discussed here tonight, for the surgery, I did have a full right axillary lymph node dissection after those 3 immunotherapy infusions. And I had what is called a non-response. I had a 30% response. And one of my questions for Professor Long is going to be something that she mentioned to me, was that maybe that the response indicator is going to change, so that maybe it won't be 50%, it might be a little bit lower, if that makes sense. But when we get to question time, I'll ask that. But mine was a 30% response from the immunotherapy. But nevertheless, I'm back on Keytruda until early 2026. So I'm now doing the adjuvant therapy after the neoadjuvant. Then I had the surgery. Now I'm having the adjuvant therapy, and I'm now 3 infusions into probably about, I'm not really sure, maybe 15 I'm going to have or thereabouts. And again, I'm tolerating it really well, not really having any problems at all. So I just hope it's there doing what I need it to do. And that's really it for me. I just have another little photo here of my family that was taken a couple of years ago. So thank you.
Thank you so much, Mandy, for sharing your story and the lovely photos of your family, and obviously starting to bring to life on a sort of personal level what a journey looks like. And obviously you're still going through a significant sort of journey now. So it takes a lot of courage, and you're very generous in sort of sharing your story this evening with people on this webinar. So thank you so much. So given just in terms of sort of time, I just have it keep an eye on the time here. What we will do is sort of go straight to questions, and understanding that the webinar was due to finish at 8. We might go a couple of minutes over, but we'll see how we go. And if there's questions we can't get to in the next sort of 10 minutes or so, we'll be able to take those questions offline and respond to those via email. So I'll just jump into the Q&A just for one moment.
Shannon, there's a few I can knock off really quickly, if you like, from a medical oncology point of view.
Go for it.
Okay, I'll do a few quick ones. Peter Edwards, 751. What purpose does the blood test prior to infusion serve? We do blood tests when we give drug treatment for toxicities. It's all about toxicities. It does not monitor the tumor. We need a baseline set of bloods, and because you can have immune side effects, which I didn't go through, they can affect any organ, rarely, but there are a few common ones. We do blood tests to monitor the person's response and side effects. So that's what that's for. Are you doing a follow-up on mucosal melanomas? I have stage 3 mucosal melanoma, Clark level on Pembro. I'm wondering if you were doing a follow-up on mucosal melanomas. I'm not sure what you mean by that question, but we definitely treat mucosal melanomas. We're doing trials in melanoma, and I showed the trial at the very end. I showed we're including mucosal melanomas in a separate cohort doing neoadjuvant, because they're part of that red third space group sometimes. In fact, a higher proportion of mucosal melanoma don't respond. And then the first one, is neoadjuvant only applied for lymph node disease, or is it trialed for distant disease? In a US trial, they included stage 4, but it was a very minuscule number of patients. Usually now with stage 4, we just go straight in with drug, and won't necessarily resect. If it goes away, we won't resect it. We won't put someone through that. Anyway, they're the first few. Hope that it saves us a couple of minutes.
Thank you so much. Just jumping to a question here for yourself, Alex. Are you able to please explain the index lymph node concept, and how is this lymph node chosen? And not quite sure what the other sort of aspect
Is it the one with the tumor?
Oh, is it the one with the tumor? Sorry.
Yeah. So indeed, yes. If you have one single lymph node, like the example I showed on the PET scan, it's easy. That is the index lymph node, the one with the tumor. If you have multiple lymph nodes that are lighting up on the PET scan, then it's the largest one. So quite straightforward.
Great. Thank you so much.
Anne Campbell's, do you want me to answer that quickly?
Yes, please.
For someone who has a 9 millimeter thick to have immunotherapy. So you're talking about a primary. I showed stage 1 or 2. That would be a stage 2 if it's not in lymph nodes, a primary melanoma. We are only doing clinical trials in stage 2 neoadjuvantly. Also, if you have an autoimmune condition, it will flare, and you can sometimes activate an immune system when something like a 9 millimeter melanoma can be surgically removed. We would not want to put you through that risk at that point. What we do think in the future, and we're leading there now, is with two places we will treat patients, either neoadjuvantly before surgery. In your case, we would not do it with ankylosing spondylitis, or if it becomes advanced, because we also know that we're curing nearly the same amount at advanced when the tumor's on board if we get it when people are well. And most people are having scans when they have stage 3 onwards. They're having regular scans and we pick it up. So with you and with your ankylosing spondylitis, I hope you don't mind me reading that out, on a TFN inhibitor, we would not be giving you immunotherapy in this situation, but it would be a discussion if, heaven forbid, you developed stage 4 later, and let's hope you don't. And there's a good chance you won't.
Thank you. I've got one more here for you, Georgina, which is related to what Mandy referred to on the percentage of response to neoadjuvant therapy, and where have the percentage cutoffs come from, and could they change over time with further research?
Really good question. I presume you're talking about the percent cutoffs in the pathological response. Our pathologists looked at where those percentages separated out patients. In fact, that was work first done in the Netherlands that did that. The pathologist in the Netherlands was looking at those cutoffs, and then they were adopted and made standard. We're still working on whether we can lower some percentages. So, for example, we may think the cutoff should be not 50% and higher for a non-response, but 70% and higher. So that is something we're definitely doing more research on. But those cutoffs were developed by looking at how people went longer term.
Great, thank you. Another question here just about what purpose does the blood test prior to infusion serve?
I answered that one.
That one, sorry. Apologies.
So there's another one about the assumption a neoadjuvant setting will be more effective no matter what type of drug is outlined, or could these therapies also be trialed for without surgery? So I don't know exactly if this is related to that question, but I think, you know, Georgina and I probably would agree on the fact that if we're talking about immunotherapy, that seems to be more effective with the target, the cancer still in the patient. So to do that before surgery, but definitely Georgina is also leading many trials looking at drug therapy for advanced melanoma. So that those are the non-surgical cases. At the same time, I think, you know, another concept we're talking about reducing the surgery in that MSLT3 trial that I'm leading, but maybe in the future we might even identify patients that need not have surgery after drug therapy, and that might be even the next step. That's a bit further away from us at the moment, and that might be odd for me as a surgeon to say so, but wouldn't that be ideal if we could, you know, simply have 2 infusions and not need surgery at all, and then I'll just go to the golf course, I guess.
Thank you so much. Just looking at the final few questions here, whether
there's one about success rates achieving when combining immunotherapy with radiotherapy in stage 3 melanoma. So we tend only to do that when we've had a pathological non-response, and there are additional features that mean we want to get what we call more local control. Radiotherapy itself does not prevent metastases. So the only thing that will prevent metastases before the surgery and after the surgery are drug therapies. What radiotherapy does is it prevents the tumor coming back in the field in which you're irradiated. So let's say you have a lymph node in the armpit. Let's say you get neoadjuvant treatment. Let's say Alex removes the lymph node and the pathologists come back and tell us in a report that it's not responded and it's burst through the lymph node. We call that extranodal spread, and it's about 3 centimeters. Then we know that's not a pathological response. Let's say it's got about 80% tumor, so it's not a pathological response. We would then continue drug therapy afterwards, and we would recommend you see Angela Hong, for instance, Professor Angela Hong, radiation oncologist, because we don't want you to recur in the armpit area. And so she would irradiate the armpit area to prevent it coming back in the armpit area. The radiotherapy itself does not prevent distant metastases. So it does not prevent a melanoma cancer cell planting its home in the lung or the liver and growing there, but the drug therapy may. So we have success rates only in local control. Radiotherapy is a local treatment.
Thank you so much. Now, I'm not sure some of these other ones that are comments or questions.
What is the Neo-Irene trial scheduled to commence, and where is it going to open up? Is this just New South Wales, Australian-wide, or international? It's very difficult for us to ever give a start date. I'm very hesitant because I manage patients and how they're feeling, and I don't want to ever give people hope that's not real for a trial. So I never give a start date, but we're hoping it starts within the next 3 to 4 months. But there are all these ticks that we have to go through. So I don't like to give a time. It is scheduled to commence at MIA then. Other sites around Australia will open. It is what we call it's an investigator-led trial. I designed it, and with my colleagues, we're opening it around Australia. It's not funded, so we're trying to raise the funds to open it in more sites, basically. But it will be open at MIA, at least MIA in the next 3 to 4 months, we hope, and then open elsewhere. But you should be able to see that online when it is actually open.
Great, thank you.
Someone asked about side effects. Oh, no.
Yeah, and Damon asked about in the event of a recurrence after neoadjuvant treatment, is research being done on the first pathology response and then comparing to the recurrence? Definitely, this is a huge area of research for us. I think that refers to the third space that you tried to explain, Georgina. These are areas where we call biomarker research. So we would love to have a blood test or a test on tissue to help predict that outcome for that patient, so we could tailor treatment and maybe escalate treatment and bring in new treatment rather than go with the regular treatment that clearly didn't work in that case.
There are sort of two related questions, actually. Maria Bowen had a question about if you don't get the full number of doses before surgery, does that affect your response at surgery? And then the other one, which is sort of related, is adverse reactions to the neoadjuvant immunotherapy, where it attacks the central nervous system. So I'll just talk about those two together. Basically, if you get a side effect because your immune system's overactive from the immune stimulants, then we may not give you the second or third dose. And does it affect your response at surgery? No. And I'm going to explain that in a little more detail. But before I do, because I'm speaking about adverse events and side effects, Nick's question about the central nervous system, they are incredibly rare. It does happen. Any organ is up for grabs when you fiddle with the immune system. The immune system is so powerful, and we are giving stimulants. Everybody's immune system is different. Some people only need 1 dose, and we can see from the fact that they get inflamed or their blood tests that everything's activated. That's enough for them and their body. And so we just sit back and let the immune system do its work. Some patients can have more because they're simply not getting side effects, but it doesn't mean it's not working. If you're not getting side effects, it doesn't mean it's not working. So they're two important points. So that's answering Maria's question. The number of doses differs for different people, different tumors, different immune systems. So don't get too hung up on the number of doses you personally get, and it does not change your outcome in surgery. In fact, we're quite pleased that not many people don't get to surgery at all. Most people just get to surgery and it's fine. In terms of Nick's question, the central nervous system, it is very rare. It's less than 1% of people will get a central nervous system attack. It can do it in various different ways. Some people, it attacks the brain. We call that encephalitis. That's extraordinarily rare. Sometimes it affects your peripheral nerves. You can get pins and needles or difficulty walking, and that's, again, very rare. They need urgent medical attention, and they are treatable with a very good team who know what they're doing. The earlier, the better. I hope that answers your questions. Lance, if there are no side effects, does that lean more towards no? There are a couple of side effects which are encouraging. and we think, oh yeah, they may be more likely to have a response, but you can't rely on that. If you don't get any side effects, that doesn't mean a thing. It doesn't mean it's not working at all. But if you have thyroid or rash or vitiligo where you lose pigment, that's often associated with a good response, but it's not a one-to-one relationship. So I wouldn't hang my hat on whether you're getting them or not as to whether you're going to do well or not. And then the last one, I think we answered that top one, didn't we, Alex? And that was about distant
I think we
mets.
did. Yeah.
Thank you so much. You've sort of whipped through all of those. That's incredible. So I will bring the webinar to a conclusion. Thank you so much, Georgina, Alexander, and Mandy as well for sharing your story. Just wanting to remind people, we do have that sort of third webinar in the series next Tuesday evening, the deep dive into sunscreen. So it'd be wonderful if people wanted to join that. The recordings for this webinar will be on the MIA and the MPA websites in the next couple of days. So for anyone that missed it or you think would like or would get value out of the webinar, I encourage you to go to the website there, and certainly the resources and information that was sort of shared by both Georgina and Alexander, I think, in the chat, and I guess they're sort of available as well. And last word was there will be a short sort of survey at the very sort of conclusion if people can hang on and complete the sort of couple of questions there. So thank you everyone for attending and giving up your time this evening. Yeah, just wish you a very good evening. Thank you so much.
Thank you.